Hi everyone, welcome to Anaesthesia Coffee Break. My name is Lahiru.
And I'm Stan.
And today we're going to, first of all, do a performance tip with Stan, acknowledge one of our Patreons, as well as go through the gravitational effects on the lung. So essentially oxygenation, ventilation, and blood flow. So let's get started.
All right, so we're going to do a shout out first to Scotty. So Scotty's one of our Patreons, and it's really interesting, his story. He was a full-time musician 5 years ago with no background in science, but now he's in his final year of med in Newcastle, and we're keeping him company on his drive up to the East Coast. So really appreciative that Scotty is supporting us, and I think it's amazing, don't you think, Lad, that we're getting so many diverse amount of individuals into medicine nowadays.
Yeah, absolutely. Like I remember, I'm one of the med school clinical fellows, and I usually ask, is anyone from another background rather than biomed science or something? And there's always quite a few people who've been, performers or artists or musicians, and like, how great is that? Like, it's just great when you think that your team in the future is made up of people who've got so many different experiences. And the amount of value add that creates to, we all work in teams now. We all have special interest groups. Imagine someone who's got that artist background or that other technical background that we just don't have. It really adds to it.
It just makes medicine better. Just having all those different skills. And you know what, Scotty? If you can, I think you can do some of our music intros and outros as well in the future. Yeah,
that's right.
Send us in some ideas.
Sounds good. Okay, well, thank you, Scotty. And if anyone else wants to donate and become a Patreon, please do. It all goes for a very good cause. Obviously, a fund a fellow to fund fellows in the third world, training in anesthesia, and we'll put a link in the story notes for this podcast and for the YouTube video. So now, Stan, performance tip.
Okay, so I'm going to relate a story that I encountered this week, and it's the idea of confidence, building confidence, especially building confidence up to an important moment. And everyone knows that, and I'm not sure whether this podcast will come up before then, but everyone knows that the viva exam is next week. And also leading up to the exam and having that confidence to go into the exam, knowing that you are going to perform at the level that you need to excel in this exam. And it's one of the things that trainees struggle with, especially during the last week. A lot of self-doubt, a lot of feelings of inadequacy. And I think that we need to have sort of techniques, or in fact, we can discuss about sort of techniques in terms of how we can improve that. So there's a couple of things that I've thought about. And one is, I think to do things that you are good at to help you build confidence. And what I mean is that, for that last week, it's all about doing things. So doing vivas that and asking someone to give you those vivas where you can have the opportunity to answer those vivas really well. I think that really helps to build confidence. And then the second thing is, which is probably the most important, is actually just take a pause and acknowledge that you are worthy and that you have actually been invited to a viva, which means that you have got the knowledge, or the college believes that you've got the knowledge that allows you to present for a viva.
That's such really good information there. And I remember going through this myself, and I was thinking about literally, not feeling so good about the study. And so I remember the other thing I did was just, if I was in like a bit of a low mood, I'd do things purposely throughout the day, or once a day, that would make me happy as well. So almost my psychological well-being performance would, I'll try to improve that. But yeah, trying to balancing your short answer, balancing your vivas with easy vivas or ones you're comfortable with, as well as going through stuff that you weren't as good at. So I remember I'd always just talk to this one friend if I was feeling down, and that would make me feel better, or go out to some place, and have a drink, and that would make me feel better. But then just knowing that I had that to look forward to would make me a bit more, just lighthearted and a bit happier about everything, which would really increase my performance as well.
Yeah. And I think everyone approaches the last week a little bit different. But generally, I think the general advice is to just take some time off to look after yourself. You've done all the hard yards, and that if you are going to do create more vivas or put yourself into situations where you have the potential to be vulnerable, do acknowledge that. So either prepare yourself beforehand to know that, what happens during that process is should not affect you in terms of what happens afterwards. Okay. And the other thing is also perhaps to communicate to whoever's giving you the Bible or the examiner that this is your last week and you just want an opportunity to build that confidence and to perhaps, whether they can, create sort of opportunities for you to answer questions which you can answer well and actually just build on that technique and build on that confidence.
Yeah, it's a really great idea. And I think most people would be pretty happy, but the highlight there is you don't need to be beaten down from every viva that you get.
No, that's right. No,
okay.
and I think, look, it's fine to do it, 8 weeks out, 6 to 8 weeks out from, before your exam, because that you've got the time to build up that knowledge. But I think closer to the exam, you've got it there, and it's and a lot of the stuff that people beat themselves up over is just some really simple stuff. Well, not say simple stuff, but as in like minutiae, if that makes sense, like really peripheral topics, which are always going to be difficult anyway. And the key thing is know the core stuff really well. Yeah.
No, that's a great idea.
All right, so we're going to move on to your discussion, which is about how gravity affects the ventilation perfusions of the lung. And you had this for your viva, didn't you?
Oh, no. So sorry, just one of the examiners, ex-examiner at my hospital asked this question. I think it was even in a group setting. And it was amazing because there's this whole section west just of this. But I'd never looked at that diagram because it just looked too scary. So anyway, after that, I definitely had a look at it.
Yeah. And so I think the question that they started off with is, how does the alveolus at the apex differ from the base?
Yeah. And I'll in the notes, I'll show you the particular diagram, but it's essentially a diagram of the lungs with lots and lots of different components, which sounds really tricky to start with, but it's actually quite simple when you just think about it logically. So for example, most of these effects are due to gravity, and gravity has all these effects on, the size of the alveolus, the compliance of the lungs, as well as gas exchange and pH. And so I pretty much just tried to remember step by step the different categories that I'd talk about. So I'd talk about size, compliance, ventilation, perfusion, and then all the gases, PO2, CO2, so PO2, PCO2, pH, and maybe even respiratory exchange ratios and pressures. So just thinking logically, because of the gravitational effects, the weight of the lung on the base means that those alveoli are going to be smaller and the apex is going to be larger. The compliance at the apex is less, however, because it's on the wrong part of that compliance curve. So on a hysteresis curve, it is in the kind of the apex. The apex alveoli are going to be on the flatter part. So that's important to know.
And it's important just to note that that's at FRC.
Yes, that's right. So as soon as you get under anesthesia, everything shifts on that curve.
That's right. Yeah, and I think that's a really important thing, is that they can shift depending on the clinical situation. So whether there's anesthesia, and also depending on the respiratory cycle as well.
That's right. And so the interesting thing is then we move on to ventilation. Now, ventilation is actually more at the more compliant section of the lung. So you'll have more ventilation at the base or wherever there's further compliance. Blood flow is less at the top, and that's the gravitational effects. So essentially the interesting thing is, while ventilation and blood flow increase increase from the apex to the base, this happens more dramatically for blood flow than ventilation. So overall, there's still higher VQ ratios at the top of the lung than at the bottom.
Assuming the numbers, like what sort of numbers do you have for like PO2 and PCO2 for the apex and the bases?
Yeah, and look, I tried to memorize these numbers. I can't remember if I actually got there, but your oxygenation at the apex is going to be high. So PO2 is about 132, and at the base it's about 89. PCO2 is less at the top of the lung, is 28, and PCO2 at the base is 42. And then your pHs at the apex 7.51 versus the base 7.31. And then you can also talk about the pressure. So, at the base it's negative. So at the apex it's -10, whereas the base is going to be more positive. It's at -2.5 in this ideal situation.
And then how about the partial pressure of nitrogen at the apex versus the base?
Yeah, so I thought this was always like an applied question because you don't really talk about nitrogen much, really. So how would you calculate that? Well, literally, one of the gas laws is that all the proportion or the pressures of each of the gases will make the total barometric pressure. So the barometric pressure, assuming you get 760 millimeters mercury, you simply minus the oxygen partial pressure and the CO2 partial pressure, and the remainder will be nitrogen, assuming there's no other gases involved. So, 760 minus 132 for oxygen at the apex minus 28 will give you your nitrogen concentration, or partial pressure, sorry.
And then why is there a pH difference between the apex and the base?
Yeah, so this is literally because of CO2. So because the CO2 is higher, PCO2 is higher at the base, your pH is going to be lower. It's slightly more acidic.
And then they often talk about, even though that the apex has a higher PO2, there's minimal oxygen uptake. So can you explain why that is?
Yeah, so that's a really interesting concept because, you might think that, well, there's high oxygen at the top or the apex, there's low oxygen at the base, but it shouldn't even out. And it doesn't even out because there's just less blood flow. So imagine all of this high oxygen, blood from the apex, there's actually just not that much blood. So a very small proportion of high oxygen blood doesn't make up for the very large amount of low oxygenated blood at the base. And so that's why overall there's minimal oxygen content being delivered from the apex of the lung.
Which makes sense, doesn't it? Because as you increase your VQ ratio, you're heading towards infinity, which is alveolar dead space.
Yeah, that's right. We're zone one.
We're zone one, yes. So now, what happens during exercise?
Yeah, so exercise just means that you increase pulmonary blood flow, increase pulmonary blood or pulmonary artery pressure. And what that does is does a whole bunch of things like recruitment and distension. So recruiting previously closed pulmonary vessels, but also distending and making larger, your existing open vessels. And that just means that there's just more uniform matching of the ventilated perfusion throughout the lung. So what this does, it essentially evens the playing field, evens out your apex blood flow and your base blood flow, giving more high oxygenated blood as well in that attempt. And then that means that you have more oxygen uptake. So increased oxygen uptake occurs with exercise.
Well, it's a very clever system, isn't it? Because I think the other thing that happens during exercise is that as you increase your velocity of respiration, the ratio between ventilation of your apex and your base actually starts equaling out too. So all this serves just to improve oxygen matching and oxygen uptake in exercise. Very clever physiology. It's
almost like you've got this, just like the body has enough redundancy and reserve just for what it needs. Right now your lungs sitting, being a bit inefficient, and as soon as you exercise and you need to increase efficiency, it evens it out. So it's far more matched. Yeah, so it is really a beautiful thing.
Now, what's the ultimate implication of this VQ inequality between the base and the apex?
Yeah, so we've probably answered it to a certain extent, but essentially you will have less oxygenation or less oxygen content than you would ideally have. So you imagine all of these slightly unequal segments, the top segments being highly oxygenated just aren't compensating for the basal segments having poor oxygenation but lots of blood. And so and Stan showed a really good graph just before to me, which kind of shows that the PO2 at the apex is a certain number and the PO2 at the bottom. So like, let's say it's 130, and at the base it's say 40 or something. When you combine the average PO2, when you just go across these segments, it ends up being something like PO2 of 58. And this number is far closer to the basal PO2 than the apex. And that just means the base has far more blood, which overcomes the amount of high oxygenation in the apex.
No, that's a great explanation. Now I think we're going to talk about distribution of blood flow.
Yeah, that's right.
And so tell me, like that's affected by gravity, but tell me a bit more in terms of how that's also changed.
Yeah, so this is really interesting. So you'll hear this term west zones of the lung, and it really just shows you that we just now talked about essentially ventilation and perfusion from the apex to the base, but west zones of the lungs talks a lot about how, what governs flow. And the fact is that gravity means that there's a lot of changes happen from your arterial and venous system, as well as some other factors, and it distributes based on gravity. So it's amazing that all of these things really are just due to the fact that we have gravity, and that changes everything. So for example, when you're just standing upright, the distribution of blood flow increases down to the base of the lung up to a certain point. But let's say you're supine, suddenly the anterior part of your lung is the apex, and the posterior part of your lung is the base. So that's how it distributes then, which then gives you certain arguments for why, like even now, I did a COVID ward round on Monday. One of the best things you can do to improve oxygenation for these patients is proning the patient to try and improve VQ matching and just better oxygenation for these patients who are struggling. And it's just such an effective thing. So, a bit of a clinical correlation. We've got these patients who are out of ICU. They're hopefully just on some Hudson mask or nasal prom oxygen. As soon as they get a bit more unwell and decrease the oxygen saturations, we use high flow nasal oxygenation. As that fails, we use CPAP, and as that fails, we use BiPAP. And at any point, you can try to optimize things by having the patient just lie on their front, on their stomach, in the prone position, and that just improves oxygenation.
So conceptually, if we were to sort of think about that, if you were to lie a patient prone, what happens is that now that the anterior part of the lung is now your dependent part of the lung. So yes, that means that your anterior part of the lung is on the compliant part of the compliance curve. So that we'll be getting most of the respiration. And then because of gravity as well, that be getting most of the perfusion as well. But I'm assuming that in these COVID patients, that what happens is that the anterior side of the lung is maybe preserved or less affected by at that current time by that COVID, which allows VQ matching to improve.
Yeah, potentially. And I think their cardiac outputs are already high. So, potentially, again, I don't know this in detail, why this works so well. Maybe we'll have to, look at it and present this in another segment. But potentially as well, the cardiac output has caused nice uniformity throughout the lung, and you want the higher oxygenation segments, which are the apex, which are now the back of the lung. There's a lot more mass, in the posterior part of the lung than in the anterior. So maybe that's it as well.
Okay.
I'll look into it.
Yeah, interesting. Now, you sort of mentioned the different West zones, and then I think it's good for everyone to sort of know what, how you think about them, and also how you define them as well.
Yeah. So yeah, West zones 1 to 4. And this was, again, a really great diagram in West, which we'll link to. So essentially zone 1 is dead space. And there's always 3 factors here that we try to manipulate. There's the alveolar pressure, arterial pressure, and venous pressure. And at any one time, your blood flow is governed by the difference between 2 of them. So in zone 1, your alveolar pressure is higher than your arterial pressure. And when you think about that, that means your alveolus is actually blocking the pulmonary artery flow. Therefore, there is no blood flow. And that's just the definition of dead space. There's ventilation, but there's no perfusion. And you might see this in, generally speaking, the apex of the lung, but also in times when there's hypotension. So the arterial blood pressure is low for whatever reason, or if your alveolar pressure is high PEEP, high pressures, ventilating someone. And that's West zone 1.
And just on that point, you sort of mentioned that high PEEP will cause West zone 1. And I think that's a bit counterintuitive to a lot of trainees, and probably a lot of anaesthetists too, because all of us will institute PEEP at some point to help improve oxygenation. But you're right in terms of what it's been shown is that in probably most patients that it's actually counterproductive because of that very fact that it causes zone 1. So you need to find that green zone, that's point right, where the inflection point of the compliance curve is at its peak.
Oh, yeah, absolutely. Yeah, when we talk about optimal PEEP, it can be so complicated. I'm sure an ICU consultant can talk very much at length at this. But what do? I set my PEEP, and if I've got real issues with ventilation, I'm really worried, I'll check the spirometry and make sure that I've got the highest compliance per PEEP. And if that's the case, then I'm pretty happy with it, because that means that I'm on the best part of that hysteresis curve, and that's my settings.
And yeah, that's super interesting. And I think I think tell the audience, like, with those settings, like how do you find the point of highest compliance?
Yeah, so luckily our measurements, our ventilators are very complex now. You can literally press spirometry and it will give you a flow volume loop, yep, just like you drawing, almost like what you draw for the exam. And then it also gives you a compliance reading. The dimensions often change, so it's hard to really get a ruler out and calculate these things, but they calculate the compliance for you. Yep. So what I often do is I go up in PEEP so that I am, overshooting the PEEP, and then I come down, because again, I want to be on the best part of the hysteresis curve. So expanding the lung and then coming down to an ideal PEEP is better than rising up to ideal PEEP. So I might go, 10 or even 15, and then slowly come down and roughly mark the point where compliance is greatest.
Okay, that's interesting.
Yeah, that's
a great tip for great little insight tip for people doing anesthesia and wondering what is their optimal PEEP.
Yeah, that's right. And then again, there's complications, because if you're using pneumoperitoneum or you're changing the position, then, or the patient state changes, then all of that will similarly change. And so, nothing's going to be absolutely perfect all the time, but it's a rough guide. And then again, if you're not worried about oxygenation, but you're really worried about blood pressure, then increasing PEEP may not be the right thing to do. So that's also a bit of a trick.
Well, yeah, good point. Is that the other thing that you also need to take care of with PEEP is that the blood pressure, that you actually have adequate blood pressure. And it's a bit, they're both opposing forces, because as you increase PEEP, you actually decrease your blood pressure because of that constriction. And and if the patient's not well volume, you can actually decrease their cardiac output as well. So very important that you've actually got, as you increase PEEP, you actually have measures in place to actually increase the blood pressure as well. Otherwise, you're going to exacerbate zone 1.
That's right.
Good stuff. All right, that's really interesting. How about the rest of the zones?
Yeah, that's right. So zone 2, this is, again, we're looking at the differences between pulmonary artery, alveolar, and venous pressure. And in this zone, pulmonary artery pressure is greater than alveolar pressure, which is greater than venous pressure. So what this means is that blood flow does occur now, but as the arterial pressure increases down west zone 2 and your alveolar pressure is constant, you get this slight rise in your blood flow as you go down that zone. So pulmonary artery pressure or blood flow is dependent on the difference between arterial and alveolar pressure, but arterial pressure is greater than alveolar pressure. And so, yeah, flow just increases inferiorly. And venous pressure doesn't have an influence on flow in this circumstance, just like West Zone 1. Then
the Zone 3?
Yeah, so Zone 3 is kind of the normal situation. When you think of the fact that we've got these three forces, arterial, alveolar, or venous, most of the organs in the body, we're thinking about arterial-venous difference, and that's what West Zone 3 is. It governs, what governs flow is normal AV difference. So there's an increase in blood flow due to distension of capillaries, again, due to the gravitational effects. Recruitment occurs of these, previously collapsed arterial vessels, pulmonary artery vessels as well, but you get increased flow. Zone 3 is just the normal situation. It's probably worthwhile.
Zone 3 is obviously the ideal, isn't it? That's the best zone.
Exactly. And it's probably worthwhile mentioning this is, look up the Starling resistor. The Starling resistor is where you've got your artery and your vein, but then you've got an external thing or an external factor, which in this case is the alveolus, that can be, restricting flow. And you get these Starling resistors everywhere, whether it's the brain, the glomerulus, the muscle in the heart causing extrinsic compression, or the alveolus, as in this circumstance.
So with the Starling resistor, that's what you described in Zone 2, isn't it?
Yeah, exactly. Zone 2 is a Starling resistor in action, where alveolus is now your external pressure affecting flow.
Now, great. And now you've got one more zone, and I also knew about this zone, but apparently, as we were sort of discussing before, I don't think it's in many textbooks anymore. So tell us about this Zone 4. Yeah, so in the edition of West that I'm taking this from, Zone 4 talks about where you've now chucked in a fourth component. So previously we talked about arterial, alveolar, and venous pressures, but now we've got interstitial pressure as well. So the pulmonary artery pressure is greater than pulmonary interstitial pressure,
which is greater than venous pressure, which is greater than alveolus pressure. And so what governs flow is that difference between pulmonary artery and interstitial pressure. It occurs at low lung volumes. You get these narrow extra-alveolar vessels, which means that there's increased resistance to flow as well. And you can imagine anything that increases this interstitial pressure will, cause a decreased flow down through this zone.
And I wonder whether at zone 4, there's actually any ventilation, whether we're talking about shunt. Because look, I think one of the interesting things is that I don't think the new version of West or the new version of Miller's has this zone 4 anymore. So,
okay.
So I think it's something that I'll need to look at to see whether things have changed since the last time we learned physiology. Now, I've always said physiology doesn't change, but maybe it does.
Once they've got the nanobots going into the lung and checking stuff out, they go, actually, we were wrong. There's no zone 4.
That's right. There's no zone 4.
turn off the zone 4 lights and go closed. This doesn't occur.
Now, with that, was there anything else that you wanted to tell the audience about
No, I think
distribution of blood flow or ventilation with gravity?
I can imagine, a question along the lines of, what are the difference from apex to base? And I think it's important to be able to talk about what we talked about first, which was, the ventilation perfusion relationships, oxygenation, CO2, pH, etc. And then also be able to decide if you want to go into your West zones and talk about what are the determinants of blood flow. And so if you can, talk about those two things, potentially the question will be one or the other, but at least you've got a really broad approach to the gravitational effects on the lung.
Yeah. Now, I just had one more question, and I think you sort of talked about it at the start, where you said that you actually memorized the numbers for the apex and the base for your exam. Is that right?
Yeah, but I'm really good with memorizing numbers. So I wouldn't say that this is something like this was my skill. And I thought, I'm potentially disadvantaged in other areas of my exam. But if I can impress with numbers, maybe that will be a thing that I can use. And I've got a whole bunch of tricks that just occur to me when I'm memorizing.
Can you share with the audience like some of the secrets of mechanation of the Lahiru brain, which allows you to memorize these numbers?
Okay, I'll go through some of the
like when you see numbers, like I can tell you, like when I see numbers, I try to create patterns.
Yep.
Same. And they may not always occur. And so what I do is I sometimes will fudge the numbers to fit the patterns that so just to help with my memory aid. But I want to hear what you do and whether
I think this is very similar to potentially many people. So I don't think it's special at all. But for example, CO2 28, 42. If I was to see that, I wouldn't just see 28 and 42. I'd see it as 2 and 2 going across, and then multiples of 2. So there's a 4 and an 8. And there's a relationship between 2, 4.
Oh, yes, I can see. Yes, 2, 2, 4, and 8. Yes.
And you might think that's trying to memorize more things, but because it's more connections, it's more ways of remembering things. So it's a mistake to think I'm trying to memorize more things. It's better to think of it as it's a more solid memory because it's got more pillars to form it on.
Yeah, I can see that pattern. So there's a 2 in the front, there's a 2 at the end, and then there's a 4 for the 42, and then 4 times 2 is 8. So 28 and 42. Okay,
that's one example.
Good stuff.
The other example is literally sometimes it's just hard work. Like when I was trying to memorize PKAs and stuff, I used time efficiently. So I was on a transport rotation where essentially you're just babysitting a patient who needs to go from ICU to MRI or whatever, and I'd just write out tables, and I'd write them out in a certain way such that the PKAs would have a relationship. So say local anesthetics, it might be 7.9, 8.1, 8.2, 7.9.
Yes.
And that together, again, creates a pattern. And I just write that out a few times and that would just stick. And then the final thing is maybe worthwhile. Like sometimes you get tables, and tables have often 3 categories: mild, moderate, and severe, let's say. And so you might think that you need to memorize 3 sets of ranges. For example, if you think of severe aortic stenosis, you've got less than 25 millimeters mercury pressure is mild, 25 to 40 is moderate, and greater than 40 millimeters mercury severe. You don't need to memorize three numbers. You just need to memorize 25 to 40. And outside of that range is, mild and severe. So to think that something is more detailed and bigger than it is probably a mistake. It really is just less numbers.
But those are some really, really good tips, La.
Okay, good. We'll probably end it there then.
Fantastic.
Nice. So hey, everyone, thank you so much for listening and watching, and please support us on Patreon if you're able to. And yeah, we'll see you again next time for more Anesthesia Coffee Break.